think there are two main limitations currently. First of all, although the pulmonary veins have been well established as the main source of triggers in paroxysmal AF, it's more unclear as to what other areas are important for ablation in more persistent forms of AF. I think the second major limitation is that even when it is clear where to target ablation, it's often the case that the lesions that we deliver are not durable. Well, there have been a number of studies recently that have brought patients back for a protocol-mandated repeat EP study after an initially successful radiofrequency PVI procedure. And these have shown that up to 2/3 of patients have evidence of PV reconnection. This includes the EFICAS-1 study published in 2014 and the recently published GAP study in which the completed circles arm cohort had PV reconnection in 70% of the patients. And also the pressure study that we recently reported also showed a similar proportion. That proportion was reduced in the EFICAS-2 study by the use of contact force and FTI targets, but nevertheless more than 1 in 3 patients still had PV reconnection. Well, the blanking periods are undoubtedly important because there are certainly a number of pro-arrhythmic factors following ablation that can lead to early arrhythmia recurrence that don't necessarily mean longer-term failure. These factors include things like inflammation related to ablation, transient autonomic dysfunction, and also the time taken for lesions to develop and mature. But there has been some data suggesting that these factors resolve within about a month after the ablation, and other studies have shown a very strong association between recurrence beyond the first month after ablation and later recurrence. In keeping with that, we published a study last year that showed a strong relationship between early recurrence beyond the first month of the blanking period and reconnection of pulmonary veins, and particularly of 2 or more pulmonary veins. So I think that all that data together, I think the blanking period is important and should be there, but there's a question as to whether the current 3-month duration is excessive. Given the high rates of PV reconnection seen in the studies that already mentioned and the disappointing success rates for ablation even of paroxysmal AF despite the use of modern technology, we hypothesized that bringing patients back for a repeat procedure after 2 months after their initial PVI with assessment of the pulmonary veins for reconnection and re-isolation of those pulmonary veins, irrespective of symptoms in the intervening period, might improve outcomes. So we studied a group of 80 patients with paroxysmal AF who were randomized to undergoing the repeat procedure after 2 months or to standard care. And we followed them up very intensively with portable ECG monitors, and we asked them to take an ECG recording every day and whenever they experienced symptoms over the 12-month duration of the study. We found that 62.5% of the patients who were in the repeat study arm had PV reconnection, and all of that was, of course, reablated. And after 12 months, the proportion of patients with freedom from atrial tachyarrhythmia was significantly higher in the repeat study group at 82.5% compared to 57.5% in the standard care arm. There were also significant improvements in quality of life, in atrial tachyarrhythmia burden, and time to first atrial tachyarrhythmia recurrence, and there were no complications associated with those repeat studies. So overall, it would suggest that until we can achieve more durable pulmonary vein isolation first time around, a second procedure after 2 months may be a potentially reasonable strategy.